Now you can hear me because I pushed unmute.
Yes, we can hear you now.
It's amazing what that little unmute can do to you. It's a hidden thing, so I have to remember to take a look at it. I apologize. I was going crazy, folks, during the break because the meeting decided to end, or I made it end, not unbeknownst to me. This is our final chapter, chapter 27, Implantology. You've had this a number of times before, so it's going to go very quickly. We can hopefully get out in a timely manner, and I'll be able to open the floor up to discussion. So let's get on with implantology. Treatment and maintenance is what we are going to be really involved with. Our job is to educate the patient about implants, and we are oftentimes the first person the patient will see to talk about hopeless teeth, missing teeth, replacing of teeth, what is optimal for them. We're not giving them the treatment plan per se, but we're showing them what the options are. And so we're educating the patient. And I had a difficult time when it came to the technology and going into the cosmetic practices versus, versus perio, that I felt like I was selling dentistry. So I had to do a little mind shift that I'm not selling, I'm really educating the patient to give them the ability to make decisions on what they wanted. What I had a hard time dealing with was some of the quote unquote selling language. If you could change one thing about your smile, what would you change? That's just not me. But we are showing the patient, we're demonstrating to the patient through pictures, through Casey or some sort of other interactive video that the offices may have. We're giving them brochures, and we're documenting every time we're talking to the patient about replacing the teeth or needing this type of therapy or recommending this or that. So what are some of the things that our patient is involved with that are changeable or not changeable in their decision-making process, as well as what makes them a good or poor candidate? So what they found is that age doesn't really relate to the success or failure of the implant. Now, age is, with the caveat, providing there's no osteoporosis involved. Okay, so that's the only providing. Okay, systemic conditions, HIV, AIDS, they are poor healers. They're not a good candidate. Social factors, are they smoking? Again, not a good candidate for wound healing. Drug abuse, what kind of drugs? And alcohol is involved in that too, can oftentimes delay or alter the wound healing process. What type of medications is the patient taking? The bisphosphonates, as you know, have that long half-life and can create an issue if bone is disturbed in any way, because it removes the osteoclastic ability of the osteoclasts. So that was redundant, wasn't it? So anyway, the body can't take away that necrotic bone. So you end up with that osteonecrosis of the jaw. But implant success and criteria for the implant, clinical immobility is success. Any mobility is not success. So depending on how you're reading it in a question or whatever, you don't want the implant to be mobile at all. So the absence of persistent and or irreversible pain and infection, again, is success. No peri-implant radiolucency, which makes sense, and no irreversible mechanical failures like an implant fracture. And implant fractures do occur, and they occur more often than we like, and that oftentimes has to do with the occlusal load, that the bite is not adjusted properly. Implant success, support of a functional restoration, that's the crown, and a lack of progressive bone loss beyond the physiologic remodeling after the first year of implant loading. Now, 0.2 millimeters. This was all done in studies, all right? 0.2 millimeters of bone loss is acceptable or less per year, 0.2. So you've got to keep that figure in mind. I'm not saying 2 millimeters, it's 0.2 millimeters. What we're looking for is osseointegration, and that occurs with the direct anchorage of the bone into the implant. They don't have periodontal ligaments. There's no encapsulation. That bone is growing directly into the implant. And there's a lot of different kinds of implants out there. They used to be smooth with holes, then they looked like screw types. Now what they're doing is they are putting coatings, rough coatings on the implants, and that roughness stimulates the bone growth in there because it allows that bone something to grab hold of a little bit better than that smooth, shiny surface. And you can see that if it's grainy, it looks like an emery board or something like that. You're not going to be able to clean that area with a scaler at all. There are different types of implants. You do need to know what each type is: endosseous, subperiosteal, transosteal, transitional, and endodontic. Okay, so endosseous implants mean within the bone, and that's what's being used today. The different root forms can be cylinder, screw type, or the blade was originally used back in the 60s and 70s, right? But now it's a cylinder or a screw type. In 1969, that was the first implant used by Dr. Brannemark. Now, he was doing implants on colleagues that were edentulous, totally edentulous. So there was a high success rate with that. We are now doing single implants and augmenting them with natural dentition, so they are a little more complicated, we're finding, with the success rate, but they're still very predictable in most cases. But direct contact of a load-carrying dental implant in inert metal with bone without any intervening connective tissue. So they don't have a periodontal ligament. There's no space. That bone is fully integrated and ankylosed. So we've got root form implants, which are on the left, and supraperiosteal implants on the right. So can you imagine where all that gum tissue, mucosa, needs to be deflected? Those metal cages are placed over the bone, and then the gum tissue is placed back. And then the implants, the prosthetic is on top of these buttons. But osseointegration is what we're looking for, and that describes long-term success of an osseo-integrated implant. It requires full occlusal function without pain, and after the initial marginal bone height loss of the first year. Now, this is the predictable area of it. You know, or the doctor knows, there's going to be bone loss of 1 to 2 millimeters at the bony crest, okay? So that height is going to resorb 1 to 2 millimeters, but after the first year, but after that, then we don't want any more than 0.2 millimeters per year. So when you're looking at radiographs and you see a single implant, you're going to see some dipping down of that bone, but, and it looks like vertical bone loss, let's say, but that is the predicted bone level after placement. Implants are usually titanium based or some sort of titanium alloy. They do have ceramic implants that are being used now with some controversy, and a lot of them are coated or sprayed to create that rough root surface. The coatings can be titanium plasma spray or titanium beads, but it's very gritty. It can also be calcium phosphate ceramics, which creates a hydroxyapatite. So you can see how grainy some of those are. Subperiosteal means on top of the bone and it's not currently used anymore. Transosteal, through the bone, not being used anymore. Transitional, they are small implants. They're called mini implants or micro. They're used for orthodontic anchorage or prosthetic rehabilitation. It provides retention, stability, and support of the prosthesis. So you can see a conventional root form versus a mini implant. Very different looking. Endodontic implants, in theory, were good. You're going through the tooth, but they didn't last very long because the tooth would fracture. And we don't see them in the United States. We have seen a couple patients coming from other areas of the world that have had something like this done. But look at where the apex of the root is here and how far down that endodontic implant is. Usually implants are done in 2 stages. They do have single stage surgeries and that needs to be pre-planned. And there's a certain sequence of events that the patient goes through, especially if there is an extraction that's going to be done and you know that the implant is going to be placed there, then the doctor can do a different type of extraction where they keep that bony wall. And sometimes bone is placed in the socket immediately after. Oh, and look at the typo here, follow-up, F-O-L-O. Okay, follow-up. Post-operatively, full workup on the patient before the surgery is done. You've got study casts, wax-ups. Oftentimes there are radiographs. It used to be a Panorex as well as a periapical, but now we're using CT or CBCT scans to show the width and integrity of the bone and not just the height of the bone, because you want to determine the quantity as well as quality or density of the bone. And the bone width, the distance between the facial and lingual cortical bone plates, you need a minimum of 5 millimeters. A Panorex or a periapical is not going to give you that. They're going to give you the measurements for the bone height. You know, where is the maxillary sinus or the mandibular canal in relation to where that root form needs to be? But it doesn't give you the bone width. The mesiodistal distance in an edentulous site or the distance between 2 adjacent implants also needs to be determined, and the bone density reflects the strength of the bone. And every, the maxillary bone, the maxillary anterior versus the maxillary posterior, mandibular anterior versus the mandibular posterior, all have different quality of bones, and it's graded. I'm not making you memorize the grading, and these are the types of bone that you have. The type 1 to type 4. Okay, type 4 is the thinnest, right? So 1's the best. It's the compact bone. All right, so again, it's just graded as to types. For the 2-stage implant, you've got stage 1 where the implant body is actually placed in the bone. The gum tissue is covered up, it's sutured up, and then they wait 4 to 6 months for the healing period, and then the implant site is surgically exposed to prepare the implant for a final restoration. Local anesthesia is used, and there's usually a surgical guide stent that's made, especially if there's more than one implant that's being done, but an incision is made through the crest of the gingiva and flaps are reflected. This is an example of what one of the stents look like. It helps guide the direction and the angle that the root form is going to be placed in. There's a series of burrs that the dentist uses, and everything has to stay wet and cool during this process. So sterile water is coming out, and because you don't want to disrupt the bone in any way. And this is a type of radiograph here. You can see the little grids that are used, and each grid is a measurement point. So it allows the dentist to really see what's going on. So the first stage surgery, again, slow speed with a lot of irrigation. The root form implant is threaded gently and tapped into position. And then a screw cover is placed on top of the implant and everything sealed over. Patients usually don't have an issue with this unless there is a sinus lift or some other procedure going along with it. But sutures are left in place for about 7 to 14 days. You want to stay away from the area. The healing period must be allowed for osseointegration. So if an implant fails, one of the two main reasons is they didn't allow for osseointegration before they started using the tooth, so they didn't wait long enough, or the occlusal load was wrong. So 3 to 4 months for mandibular, 5 to 6 months for maxillary bone. Okay, this is for osseointegration to occur. Some manufacturers claim that implants can be loaded as early as 2 months after placement. Dentists are very leery of that because they want to ensure success of the implant, so they err on the side of caution. 3 to 4 months for mandibular, 5 to 6 months for maxillary. Then the second stage or the uncovering surgery can take place, and that is with local anesthesia. They make a flap, a temporary screw cover is placed on, and so you've got a little button on top of the gum line then, and then that area heals to allow for interproximal and the gum line area, so to speak, to decide where it's going to be. Okay, that stays like that for about 2 to 3 weeks, and then impressions can be taken for the final restoration. And then the crown can either be cemented or screwed on. They're going back to the screw type implant crowns now. They started with screw types, then they went to cement, and now they're going back to screw types because they're finding that the cement acts as calculus, and if there's any excess cement, and that stuff cannot be removed by a scaler, you need a high-speed handpiece for that, but that also causes peri-implantitis if there's excess cement. There are single-stage surgeries where the implant body is placed in the bone and a portion of the implant body or collar is left exposed, and the loading, the actual loading occurs at a later time. There are clear choice offices out there which will do full mouth extraction and immediate single stage surgery. They leave with with a temporary denture. They have to be on very soft foods during the healing time, and once everything is healed, then they can make a permanent clip-on restoration for that. But for single stage surgical procedures, for earlier immediate loading, the implants are placed with primary stability, right? They're being put in, and as long as the forces are controlled and below the critical movement threshold, healing can take place. So again, things are left out of occlusion. You're telling the patient, don't be chewing on that side, that type of stuff. Some of the drawbacks are it can really increase the healing time. There can be more pain and swelling. There can be also ridge defects after extractions. I found this on the internet. It's supposed to be a before and after. Yeah. Not sure if this was Photoshopped, but this is what those advertisements are showing. Look at what the difference an immediate overdenture can do. Okay, so this is not saying that the patient had individual implants. This is actually a denture that was placed. For socket preservation with tooth extraction, you want an atraumatic extraction that preserves that bony socket, and sometimes a bone graft needs to be placed in there because that bone will automatically resorb, and that will keep that interdental papilla in more of a natural position. Implants used to look like implants. We could see the metal ring around an implant with how they were placed. Now you really don't know that there's an implant there. Now this is what that bone graft looks like in an extraction site. So single tooth implants are a treatment option, especially for anterior teeth, but for posterior teeth as well. It's good when you're concerned about aesthetics. We're no longer needing to place a 3-unit bridge in there. And there's a high success rate. If it's successful, it's successful. If it's not successful, it usually isn't successful within the first year. But patients may require additional surgical procedures to increase the bone height. So they might need bone replacement grafts, guided tissue regeneration, sinus bone grafts or sinus lifts for the maxillary, and distraction osteogenesis. Okay, that's if the jaw needs to be expanded a little bit. It's performed to increase the height of the posterior alveolus, and the surgery to expose and elevate the sinus membrane from the floor of the sinus. I have only assisted in one of those, and I did not like it. And you can hear throughout the whole office when a sinus lift is being done, because it's tap, 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 tap. And you know, you're scaling going, ugh. But a bone graft material is used, okay? Sinus lift and ridge augmentation. So even though the patient has no teeth, we can get them into a functional bite very nicely. Now, this is going into, E is going into the maxillary sinus here. And then a bone graft is placed. These are the tacks that are used. Now, I said tacks were used also for guided tissue regeneration. Now they're using the absorbable or resorbable type of barrier membrane, so you don't see that very often anymore. Distraction osteogenesis is a procedure to increase the height of the alveolar ridges. You'll do that sometimes, distraction osteogenesis, if you're trying to lengthen the bone of one leg, for example, you know, and they're cutting it and stretching it and then having the two pieces come together. So the bone is cut into two pieces, separated by 1 millimeter a day to form new bone. So there's usually some sort of a crank involved here, just like a palatal expander is an orthodontic appliance for the palate, okay, to expand the palate. This looks a little more barbaric, but it works, all right? And this is the cranking here, all right? Distraction osteogenesis. So for completely edentulous patients, the final restorations ideally are a fixed prosthetic or an implant-supported overdenture versus a complete denture that is completely removable because it stops that ridge resorption. It gives the patient more chewing capability, and cosmetically, aesthetically, it just is so much better. Mandibular prosthesis, removable dentures, and partial dentures are ill-fitting for almost everyone because that ridge disappears to nothing over time. So if the patient can have an overdenture like this, it clamps in and it helps reserve the bone of the mandible beautifully. They can have fixed partial prosthetics as well as a single tooth. There used to be a protocol where once a year the implant would need to be taken apart and taken off and cleaned and put back on. They're not doing that anymore. But it's up to us to check the gingiva around the tissue around, the implants. So we're looking for peri-mucocitis, that gingivitis around an implant. We're trying to figure out ways to fix it if it needs to be reversed, as well as we're taking radiographs to make sure that that bone is still adequate. So after surgery, the gingiva heals around the abutment and you get some sort of a gingival sulcus. On natural teeth, you've got the junctional epithelium that provides a seal at the base of the sulcus, but on implants, you've got a junctional epithelium that adheres to the implant surface, but that junctional epithelium is called a peri-mucosal seal. Peri-mucosal seal instead of junctional epithelium. And that's why you need to be very careful when you're probing around an implant. You don't want to puncture that peri-mucosal seal. And implants have connective tissue fibers, but they run parallel to the tooth surface. So think about the other PDLs that we have. You know, you've got oblique and you've got them going all different directions. These run parallel. And implants don't have cementum, so that bone is going directly into the implant, right? But you've got those gingival fibers that are running horizontally. Then you've got your biological environment of a natural tooth versus a dental implant. I'm going to let you take a look at that. Now, there's no blood supply to the implants. That makes sense, right? Because you've got a lack of periodontal ligament that limits the blood supply to the area to only the periosteal vessels as well as the bone marrow space. So oral biofilms can actually grow faster, oftentimes on titanium than they do on the enamel. And there can be more widespread inflammation around implants. So infected implants have an earlier and more rapid bone loss. So we really have to encourage our patients to come in for frequent recare and evaluation appointments. They're finding that the pathogens around an implant can be very much the same around natural teeth, depending on which studies you look at. And pathogens associated with peri-implantitis, they look like the typical offenders, don't they? P. gingivalis, T. furcimpus, P. intermedia, AA, spirochetes. So it's everything that we already can have in perio disease. So an implant maintenance program is important. Continuing care is critical, and that's where we come in, as well as patient education, to continually assess the biofilm accumulation and evaluation of both the hard and soft tissues. What does an assessment of an implant look like? It looks like every other visit that you're doing for your patient. Yes, you're cleaning the abutments and you're using whatever instruments your office has. They come in and out of fashion, right? The typical mantra is you use like with like. So if you have a titanium implant, you want to be using titanium instruments, right? We have plastic instruments that are medium filled plastic instruments that Hugh Freedy produces. Plastic instruments have gotten bad press because the plastic has been shown to leave little shards of plastic around the threads. Now, if you have a thread that's exposed on an implant, you have a failing implant to begin with. We're not going to be cleaning that. We're sending the patient off to a periodontist. So you don't want to use plastic instruments around threads. You can't really clean them effectively anyway. But our plastic instruments are safe, according to Hugh Freedy. They're safe. They're carbide instruments. They even have ultrasonic instruments with sleeves on them, so you can use an ultrasonic, magno-restrictive, or piezo ultrasonic. But the procedures that we do are really the same that we're doing for any other area of the mouth. We're just using very light pressure. Probing is still controversial. You want to follow whatever your office wants you to do. We are probing in the clinic. We are probing in private practice. Most offices are probing. Some will say we're just using a radiograph because you freak out. Oh my gosh, I've got 5 millimeters. What does that mean? Well, I don't know. We have to see how much bone resorbed the first year after placement, and is it stable? It could be very stable at 5 millimeters. So unless you have the history of the implant, we really don't know. And if things are stable and non-mobile, we have to just take it as where we are when we see the patient that particular day. So probing, again, we probe. Your office may not. Go with whatever your office wants. Probing may create a pathway for bacteria to enter through the peri-implant seal. So you're probing from one site to another. You're carrying bacteria from one site to another with your probe. And if you puncture that perimucosal seal, then you could be, again, inoculating with that type of bacteria. So probing forces are different since there's a lack of connective tissue. You're not really going to get that same feel around an implant. The consensus is that gentle probing with a plastic probe is good. Some offices are using metal probes now. You do have a plastic probe. We included that. We want you to get experience with it. But changes in the periodontal measurements over a period of time may indicate disease activity. We can't measure 0.2 millimeters, but we can measure 1 millimeter. So, peri-implant probing. Again, the book is saying no probing is necessary. Now we do probe. One of the things we probe is for looking at the condition of the gingiva around the implant as well. So you need to know what's going on in the patient's mouth. What is your policy on implants for your particular office? So that's something to ask. This is one of those nice probes that has a pressure stop to it. I have not been able to find any of these probes for about 20 years now, but when this piece of probe touches this piece, that means you're at that 10 to 20 grams of pressure and you stop pushing, okay? So that is one of those nice probes. So this means here you stop pushing, you're at the base, and you can even see how blanched that tissue is. Okay, again, 10 to 20 grams of pressure. Bleeding on probing, what does it mean? Okay, probing sites can be inspected for the presence of biofilm and other irritants. Bleeding may be caused by you, okay, operator, versus inflammation. You're looking for keratinized tissue. Do they have an adequate zone of keratinized tissue? If they don't, is recession happening? What's going on there? They might need a graft. Radiographs are used. We typically will use one of those gridded films. These were in the old days. Periapical or vertical bite wings. You're looking at bone height and bone density. Again, you're looking at that 0.2 millimeters or less of bone loss. Radiographs can be taken every 6 to 12 months, depending on the protocol of the office. You're always looking for mobility. There should be zero mobility. Okay, you have no periodontal ligament. There's no hammock going on there. So mobility of the superstructure is checked by wedging a curette between the prosthesis and the abutment. So as you're scaling, you're kind of wiggling it to see if that crown wiggles, right? It's not the implant wiggling, it's the crown, because sometimes that crown can become loose and unscrewed. So criteria for success includes frequent inspection as well as debridement, no mobility. The prosthesis needs to fit accurately and securely, no trauma from occlusion, no radiographic radiolucencies around the implant, and we need the patient's behavior to be in line with maintaining that. Now, one of the biggest factors for implant failure is occlusal discrepancy or occlusal overload, and that's excessive occlusal force of implants, because that can result in mechanical failures of both the implant as well as the prosthetic superstructure, and that can create loosening as well as marginal bone loss. Know the difference between peri-mucocitis, implant mucocitis, and peri-implantitis. So the mucocitis is that reversible inflammation of the mucosa, and it's plaque-induced, okay? It's gingivitis around a implant. Versus implantitis, peri-implantitis can be graded from slight, moderate to severe. That is bone destruction around the implant. Right, this is mucocitis, inflammation. And what is that caused by? You'd have to take a look at the fit of the overdenture there, what's going on with the patient's ability to clean, what's the fit of that overdenture, versus this is implantitis. You can see that there's bone loss around the implants. Okay, bone loss, mucocitis versus implantitis. Okay, bone loss is implantitis. These are the threads that are exposed. And like I said, when there are threads that are exposed, it is a failing implant. You need to get them to the specialist. Right now, this happens to be a surgical site, but you can see cement here, residual cement. This is why they're going back to the screw type. The only way to get rid of that is to flap the tissue and have a high-speed handpiece drill that off. More implantitis that is being surgically treated with bone fill and a barrier membrane, bio-loss. So when you've got a patient with implantitis, now again, this is just if it's at the very beginning, treatment is always going to be with oral hygiene instructions, and there can be non-surgical therapy that you're involved with. Debridement, controlled release antibiotics, they're using lasers now also, and mouth rinses like the chlorhexidine. For moderate problems, they may require antibiotics or flap surgery, and severe problems oftentimes requires removal of the implant as well as bony fill and then replacement of the implant. So this is a flow chart that is in your book that you can kind of use as a guide to what do you need to do with what, okay? Excuse me, and your office is going to have their own protocol on when to refer, unless you are at the periodontist and you are the ones that get the greater than 5 millimeter pockets. There's a whole routine of removal and replacement of the superstructures. I'm not going to make you know this. Just review it, because there is a sequence of events. You take everything apart and lay it out in a sequential manner. It all gets cleaned and inspected, and you put it back together again in the reverse order. What are some of the appropriate instruments for implants? You do have some in your instrument kit. You need to be able to get to where you need to clean, and if you can't reach it, the patient can't clean it. But you need to have the correct armamentarium for the superstructure removal. Everything needs to be unscrewed. I've never seen this happen in a hygiene room. I've seen it in the back office, so to speak, with the dental assistant, because it does take a couple of hours when all of this needs to be done. So again, you're taking things apart in a certain way. You're laying them in that sequential manner, and then you're reversing everything to put it all back together again after it's all cleaned. Okay, and a lot of times this can go in the ultrasonic bath with special cleaner. Metal instruments can scratch, so we want to be very careful. These are some of the first instruments that were out. Over here on the right, I had a whole set of these things. I never knew what to do with them. I knew what to do with things that looked like a regular instrument, but that I just never knew quite what to do with. So now the instruments are looking like your regular scalers and curettes. This is one of the carbide instruments, the black ones. Premier makes them. And the plastic ones, similar to what you have for Hugh Freedy, but you use them like your regular instruments. This is a sleeve that goes over the ultrasonic tip that doesn't scratch. And you wouldn't use the ultrasonic without this particular end. Some offices irrigate, and depending on what you use, we're not using chlorhexidine to irrigate with anymore, because at least in office, it's fine for the patient to irrigate with it at home, but after bleeding, it's best to stay away from that in the pocket area. We want to be careful and not be too aggressive. We don't want to blow out that attachment. Flossing has also been controversial around implants and how to floss. Now this is, think about where that root form is and how thin it is compared to the natural root of the tooth. So the sulcus area where that floss has to be wrapped around is very different from a regular root. So the patient really has to know how to make that C or horseshoe. They used to have a lasso the floss and wrap it around. So one would be coming on this way, and then they'd wrap it around and bring the other end this way, and they'd shoe shine it back and forth. That's not being recommended anymore because they found that floss threads could be left behind. Interdental brushes have to have the plastic coating. Perioids are great. It's that handle with the toothpick on it, okay? Or tufted floss. So you're not advising the patient to do anything different than if they were really trying to take care of their natural teeth, depending on what spaces there are. Even if they just had number 6 or number 11 all by itself, the 2x2 gauze might be more effective for that area than regular dental floss. So how would you advise a patient to take care of an area like this? Right, this is that shoe shining, but with shoe shining, you'd cross these over in the front. Proxa brush would fit very nicely in here. All right, let's take a look at a couple questions. Which of the following similarities is common between dental implants and natural teeth? Yep, you got it, B. The presence of keratinized gingiva is important around implants because it may improve tissue health. One of the questions you love. Okay, it just makes sense. Which of the following signs indicate implant failure? Very good. All right, so we're wrapping up. Controversy exists regarding the use of periodontal probes. We're going to probe. Progressive bone loss is a pathologic sign and can lead to implant failure. What is the accepted implant bone loss per year? What is the bone loss accepted per year? Point 2. All right. The implant should not be mobile. Mobility indicates lack of osseointegration. There are a lot of different types of prosthetic designs. There have been times where I could not figure out for the life of me how to get underneath an implant fixture, and if I couldn't do it, I was warming up toothbrushes and angling them. Oh, I could not get anything for the patient to get underneath with either. It was like I was just shrugging my shoulders. Who thought of this one? It was a recipe for disaster. Implant placement can be done in a single or two-stage procedure. Metal instruments should not be used on dental implants. And I found this on Facebook. Pretty freaky, huh? Okay.